Good morning, everyone. We are so glad that um, you are with us today. We are actually going to, I know a lot of folks have those great like Read AI and note like auto note takers, but since we want to do some breakout rooms and some other stuff today, we're going to move the note takers out of the meeting for a little bit. And then if you want to add them back in later during Melissa's presentation, we're happy for you to do that. But for right now, we're gonna just have those out of the room. But look, love seeing so many friendly faces today. You are welcome to keep your camera on or off. Just make sure you're muted. We're very excited to have our experts here to talk with us about authentic community engagements for CHNAs today. And with that, I'm going to hand it over to Landon from the Alliance.
All right. Well, good morning, everyone. My name is Landon Campbell, and I'm the program manager, one of the program managers for the Alliance for a Healthier South Carolina. I want to thank you all for your time or taking time this morning to join us on our second virtual learning session for our CHNA/CHIP Community Collaborative. So with that, I would like to turn it over to the rest of our team for their introductions.
Hey, I'm Pam Gillum. I'm the director of the Center for Applied Research and Evaluation in the Arnold School of Public Health. And I am co-leading this effort to share best practices and lessons learned around CHNAs and CHIPs in South Carolina. Melissa?
So today we're going to talk about authentic community engagement and why they are so important for the CHNA process, and how they build deep connection with community. We're also going to share some presentations from a couple of our healthcare system partners and then end with a Q&A at the end. So I want to
Before we get started, Melissa, can everybody finish their introductions and then we'll move into the exercise?
Sure.
Hannah and Melissa, do you want to introduce yourself and where you're from?
Yeah, I'm Melissa Fair, and I'm from Furman University's Institute for the Advancement of Community Health.
I'll go ahead. Good morning, everybody. I'm Hannah Hogue. I'm with the Alliance for a Healthier South Carolina. I'm a couple weeks on the job now, and I am a program manager for the collective impact and action work alongside Landon.
Hi, everybody. I'm Carla Julin. I'm a project manager at Furman's Institute for the Advancement of Community Health, and I work alongside Melissa Fair on this project.
Hi, everyone. I'm Katie Zenger. I'm working with the Alliance to help move this project along. Thank you so much.
Are we ready to get started?
Yes.
Landon has a quick slide.
Oh, yes.
Yeah.
All right, I promise I won't take up too much of y'all's time this morning just to go over some basics from the Alliance's point of view. So I'd like to touch on our broader work at the Alliance through the Duke Endowment really quickly. So collective impact and action aims to support our assessment and planning efforts across the state and at the local level. So we approach this process with four complementary objectives. First, we provide a robust set of secondary data dashboards alongside the Department of Public Health through the South Carolina Health Compass. So that is a free resource online, and these dashboards are based on the priority areas that were highlighted in the 2023 State Health Assessment. And they compile a long list of indicators that would be useful for action planning, grant writing, higher education, research, as well as advocacy. Our second objective is basically what you guys are here for today. So we are working across the state with a lot of different teams that are focused on their CHNA work and then also their community health improvement plan work to basically be able to create resources and provide learning sessions for them across the state. Our third is focused on the results-based accountability framework. So we offer a robust set of trainings through the South Carolina Office of Rural Health and SCAHEC. We have these free online modules as the first component, and then we kind of follow that up with in-person workshops to help teach you this framework and then actually apply it to action planning. So the in-person workshops are done for 2025, but we will resume those in 2026. Those online modules are available at any time and are asynchronous, so you can sign up for free. You actually get some CEUs for that information as well. And it's definitely a very good overview or introduction to the results-based accountability framework. And finally, we are integrating the Clear Impact scorecard system to help us track and share the progress on our action plans and our other kind of focus areas, such as our CHIPs. So this common framework and reporting method will allow us to have greater crosstalk between our different plans and will also allow us to align between our state and local level efforts. And with that, I'm going to go ahead and turn it back over to our experts so we can get back into the meat of our meeting today.
So to get us started, I want to start with a trust building exercise that the hope is that you could take this back and use it in your own work. One of the things that we know is that trust often comes with knowing each other beyond just our professional titles or roles. And so the purpose of this activity is just to build fast and what feels like casual connection with community partners and people that we're working with. So this activity is called Two Windows Open. And the goal is that we are opening we're going to take a few minutes in this virtual space to open one window of ourselves and then another window to someone else. So in just a second, Katie is going to put you into randomly generated breakout rooms where you're going to see 3 to 4 people and you're going to pick one prompt each and share them with each other. And so today I want you to talk about what's something that meaningful that shaped you recently, what's one community issue that matters to you right now, what's something small that is bringing you joy right now. And then we're going to come back as a group and talk about that really quickly as a reflection and then move into our webinar.
What kind of reflection that they have.
So, all right, we got 30 seconds.
Welcome back, everybody. We hope you had a nice little chat with your folks in your breakout room. We have about 5 seconds left before everybody's going to be automatically returned. So we hope you have some reflections and maybe got some good information from your partners. All right. That is should be everyone. Go ahead, Melissa.
Okay, I've got something on my screen that says breakout rooms. I guess, can I just click the X?
Yeah.
Okay. So I hope everyone had a moment to share with each other and build a new connection. So what I want to hear from the group, just kind of popcorn style, if whoever wants to share, is what is one thing that surprised you about what you heard? What's one connection or similarity that you found? And how did it feel to meet someone new that you've never met in this way before? And feel free just to come off of mute, whoever wants to share.
Well, I was kind of
Okay.
disappointed.
Oh, go
Sorry.
ahead, Darren.
I have to say, I was disappointed. Y'all put me in rooms with 2 great people I already knew, so I didn't get to meet anyone. So foul on that piece. That didn't work. But it was great to hear people's what meaningful things that they had, both in their professional life and their personal life, and excited to hear where the folks that I was in there with have been um, working along in their professional career, moving up and doing a lot of different things. So it was good to catch up.
Anyone else want to share?
I'll share. I'll go with the what did it feel like to meet someone new in this way? I felt like I was like speed frenting
Yeah.
Like you have this amount of time to talk to a person that you never met before. And I enjoyed it because I didn't know anybody that I was talking to, but we spoke as if we were familiar with each other. But I do outreach for my agency, so talking to strangers is my thing. So I really enjoyed meeting new people and listening to their stories. So
That was the goal. So y'all did
yeah.
a good job. Anyone else?
Our group, we all answered the same question, the joy one right now. And the similarity we found is we all talked about family.
Mhm.
And I think on the small thing, we had a common theme of gratitude um, that was amongst the three, personal or professional.
Yeah, and I think y'all are picking up on one of the other goals of this activity. It's that no matter how different we might be, no matter what lived experience or professional experience that we might bring to the table, a lot of us share the same underlying commonalities about things that matter to us or things that bring us joy. And so my hope is ultimately that this is and other activities like this. I'm going to share some additional resource guide that has, I think, more than 70 activities that you can try like this. And what I found with my organization is this is a really useful way to build partnership and get to know your community partners in a way that doesn't feel forced or stiff, and also not too silly. So I'm going to go ahead and keep us moving and get us started on the rest of the webinar. If my slides will, okay. So what we're talking about today is this idea of authentic community engagement and the power of community engagement. So one of the things that we sometimes have to do in this work is examine our lens and our mindset when we're working with community partners. Often we enter this work with some of the best intentions of wanting to make things better or wanting to improve things. And sometimes this results in what we call a fixing mentality rather than a partnering with mentality. And so sometimes that partnering with community and working with community rather than doing to community takes reflection and practice. And so the goal of today is to think about how we can move from fixing to partnering. To get us started, I want to center us in some shared language and common definitions. So one thing you may hear throughout this webinar and future webinars is the word community voice. And what community voice is the input, opinions, and expertise of the individuals who are most affected by a particular project, policy, or issue. And it's actively involving community members in the decision-making process to make sure that the perspectives of those who are affected by the issues are heard, understand, and ultimately feel valued. One of the ways that we do that is through sharing community power or building power in community or recognizing the power that they already have. And community power is the ability of communities who are most impacted by inequities to develop and sustain and grow and act together through democratic structures, set agendas, public discourse, and influence people who make decisions. It requires relationships, mutual accountability with the people who make those decisions. So why do we do this work? So one thing we know is that it just feels fair and the right thing to do. So some of the people who were most impacted by the complex issues we're trying to solve, like substance use disorder, mental health, heart disease, diabetes, have often been mistreated by the systems. We've all heard the stories of the Tuskegee Airmen who were intentionally affected with syphilis to study the disease, Henrietta Lacks, whose immortal cells were taken without her permission, and while they went on to do amazing things and innovate in science, her contribution wasn't recognized. And so it can help restore trust and build relationships with those communities who historically have mistrust in the system. It can shift and share power with our community partners. It also builds systems of trust and accountability. It fosters open and transparent mutual communication. It also makes sure that we honor our commitments to each other, both from the partner side as well as the community side. One of the other things that we found is it often leads to better outcomes. People are more likely to participate in programs or initiatives that they trust, that they feel like honors their community context, their heritage, and so more likely to increase our uptake, which improves our outcomes. It also maximizes innovation and ideas. Sometimes the best ideas and solutions come from the people experiencing the problem. It also lets us problem solve and design together. So one of the things that I want to talk about is this idea of lived experience and trained experience. Both are incredibly important, and we need both at the table, but they can't be substituted for each other. So lived experience is just that, direct experience with an issue or a problem. We all bring our own individual lived experience, no matter who we are, to the table. Some of us just have different ones than others. So if we're trying to solve food insecurity or housing insecurity, or if we're working on a specific disease state or condition like diabetes or heart disease, we want to engage people who have direct experience, whether that's through their own selves or through the people that they love and care about, like friends and family, in the process. We also have trained experience, and so that is our education, our certifications like community health workers, our professional applied experience in doing this work that we acquire over time. And sometimes we have people who have the intersection of both of these. Our community health workers are a really great example of where we have the intersection of trained experience and lived experience together. But one thing that we have found is that sometimes we want to substitute lived experience only for people who have both trained and lived experience. And one of the problems with that is once we have trained experience, we often have access to different capital, such as different jobs that might be better paying. We have access to education that helps us navigate the healthcare system better. And so we might lose the perspective of the people who don't have that trained experience if we don't include them at the table. And so we need the matrix of all of them. We need people who may have trained experience only. We need people who have both trained and lived experience, but we also cannot forget the missing puzzle piece of people who have lived experience only. So what does that look like? So one of the things I wanted to share today is this continuum of community engagement. And what I want us to focus on here today is that on this continuum, you don't all have to get to leading. You need to examine the purpose and the intention of your work and set out and design your CHNA or your program or initiative that intentionally works to get to that place. And so if involving or collaborating is what makes sense for you, you set out and design your process to get there. And so I wanted to talk about a couple of examples of what inform, consult, involve, and collaborate might look like. Because one of the things that we do know is that it does get harder as we tend to move up that continuum. So inform, as you can see here, is really sharing information out. Examples of that might be presenting data back to your community partners once you get it from your CHNA. It might be sharing information or resources about the programs or the initiatives that you start as part of your CHIP. The next stage up is consulting. And you can see here where the arrows are pointing in. That's where we're pulling info in from our community partners. That's things like survey inputs, hosting focus groups, town halls, listening sessions to consider and use their input, but it doesn't have a bi-directional relationship. So when we move to involve, you can see for the first time, we're really sharing information back and forth, but roles and decisions may not be as clearly defined. This might look like inviting a community partner to serve on your steering committee or participate in your work groups, but there may not be governance structures or formal roles and responsibilities. Once we get to collaborate, there is that more formal structure. There is more shared decision making. Community partners may have an active role in deciding and implementing and making sure that parts of your CHNA or your CHIP come to fruition. And then finally, we get to the space of being community led. And in the space of community led, that is the community truly owns the process. And healthcare systems or health partners are just that, a partner in the community process. And so that may not make sense for every health system as they're working in their CHNAs, but we have found that it does for some. And I think we're going to talk about an example of that with Tri-County later in the webinar. So some of you have seen this before. This is one of Pam and my favorite visualizations, and that's our stakeholder wheel. And that just kind of grounds us in who, when we are forming the CHNA steering committees and working groups, needs to be at the table. We need to consider our local elected officials, people who work for local health departments, other government employees who may have influence over policy decisions or access. We need our organizations and our coalitions who might be working around specific issues such as healthy eating, active living, diabetes, injury prevention. We need private sector at the table. That's often one that is really hard to get, but they have great influence, especially in the space of policy and systems decisions. So think of your Chamber of Commerce, professional associations, the health insurance and health industry, so payers. We also need other healthcare partners, so our free medical clinics, federally qualified healthcare centers, maybe urgent care centers. We need our education providers at the table, and then people who work in the space of complementary services like parks and recreation. And then also we have community services. The only thing that I would tell you that I think is a missing piece of the puzzle in this wheel is we don't have community members. So there's no place for community leaders necessarily to show up in this wheel. And so I would say that would be the only change I would make to the wheel, is to add a space where people who are just showing up because they have a voice in the community and want to be heard are at the table. So what are some community engagement strategies? I really want us to challenge us to think about them as more than just listening sessions or surveys. Those are vital to our CHNAs, and most of you, if not all of you, are already doing that in some form or fashion. But they're moving up that continuum. There's even more that we can be doing. So one thing that we have seen communities do are community advisory boards, where there's a formal governance structure, there's regular meeting cadence. It's a way for people of lived experience to regularly interact with their health system partners and get input and share insight and be a part of the decision-making process. One thing to consider with community advisory boards is it's a huge time investment, but it also has the opportunity for huge impact. Another strategy is to embed community members in your boards and your working groups. So that requires less time investment and I guess, resources than building a community advisory board, but you do need to develop intentional strategies and co-learning opportunities for how to integrate your community members into your boards and working groups so that they can have a shared understanding of the language, so that they know the process and can actively be engaged in the work as much as the staff are. Another strategy is to make sure that you're including people with lived experience and who have that intersection of lived experience and trained experience in your process. So think of things like peer support workers, community health workers, and case managers who have direct access to priority populations and who are able to kind of help serve as a bridge to that voice for community. They can often help facilitate the process of engaging community members in your boards and working groups, and often can make them feel more comfortable and welcome at the table because they see a familiar face. And then the last strategy that I'm going to share today is to consider something called participatory action research. And that is just that. Community participates in the research, and it's active research. So while your CHNA is not a research project, there are research principles that you can bring in. And so participatory action research is this idea that from the very beginning, our community partners or community members with lived experience are at the table helping us define what are the data sources we want to understand? What are the questions that we need to know? And so they may help guide your survey development. They may help you think about which questions you need to be asking in your focus groups. They may help you decide what your prioritization process is going to look like. And so they have a shared ownership of the CHNA process and have some decision making over what the CHNA looks like. So here you can see, I'm not going to go through these one by one, but we are going to share this PowerPoint after the webinar and make it available for everyone. And so we've included some resources that we have looked at and vetted and think that are really good resources if you're looking to engage in this process of community engagement. So one is the Healthy Tri-County Community Health Needs Assessment. We're going to hear from Renee Linyard-Gary later in this webinar. So the Tri-County Community Health Needs Assessment is just that, 3 counties working together. It's a community-owned process where community partners are at the table and multiple health systems are at the table. Another is a community asset mapping resource that is often really helpful for community partners as they're thinking about prioritization and developing their CHIP. What are the existing assets that are in your community? How can you maximize them and leverage them? Another is how do we center community voice and engage stories of lived experience from the Georgia Health Policy Center? Another is a dialogue process for catalyzing community change. So how do we facilitate dialogue with community? The next is a toolkit. If you're looking at that community participatory action research, community engaged and participatory methods toolkit. And then the last is a stakeholder identification analysis. So if we're looking at that stakeholder wheel and we're building our stakeholder groups and our working groups, one of the important activities for you to do could be to walk through and look at who is at the table, who is missing from the table, and so who do we need to engage in the process that is not currently here? Okay, so what have we learned? So one of the big takeaways when we are engaging community partners is that money and resources really matter. We need to compensate people of lived experience when we can, if we're bringing them to the table, especially in the space of community advisory boards. So if we're saying this is a formal meeting board, we want you to take time in your day and come and meet with us, help us make decisions, lend your expertise, we need to consider compensating them for their time, because when we are often part of boards or working groups as part of our jobs, we're being paid to be there. If you want to build community advisory boards or engage community, you may need to think of the barriers that they may experience. And that may include things like, do they have childcare to attend meetings or working groups? Do they have transportation needs that look different from yours? So that can include things like offering a transportation voucher where maybe they're going to take an Uber. It can be working with your peer support workers or your community health workers to offer rides. You're also going to need to invest in that community leadership. They may need leadership training or professional development, especially when we're trying to talk about these really complex issues that require policies, systems, or environmental change initiatives. Another takeaway is take small steps. You don't have to do everything overnight. You can start very small, like with one piece of the puzzle. So maybe your CHNA has only done surveys today. So maybe the next step is as simple as to say, let's do some community listening sessions and share our data back with the community and get their input and see what this data means to them. And so this idea of sense making sessions with data, that can be your first step, and it doesn't have to be daunting. Your organization or initiative might not be leading in the work, but you can still be part of it. So if you can show up and be a part of community work, you don't always have to lead it. And that's also sharing power with community, being willing to show up and say, I'm going to be a part of your table. I'm not only going to ask you to show up to mine. Another is it takes practice. You're not going to get it right the first time. It may feel uncomfortable. You don't have to be an expert to get started. What I would really challenge you to do is when we show up to do this work, our job should be first to listen and learn together with the community partner rather than to feel like we're the expert in the room. This can often be really challenging because as professionals, that's how we're trained. We're trained to show up and lead first with our expertise and experience in the room. And so sometimes we have to take a step back and examine that lens and say, how do we show up as an equal partner with our community partners and community members and listen? I can share an example of what that of a time that we didn't get it right in doing our work. So the IACH partners with local coalitions, and one of the things that we did was they asked for a health equity data presentation. And so we came in and we shared data about how differing life expectancies were by zip code or census tract. And showed the stark disparities of morbidity and mortality related to chronic disease. We also showed how historical residential segregation might have influenced some of those patterns. And what we didn't think about was the unintended consequence that for some community members and partners, this was the first time they had seen some of this data. And it was painful to hear. And we didn't come equipped with a way to debrief or have dialogue or have a trusted community leader in the room prepared to guide that discussion with community partners. And so the next time we did it, we got it right. And ultimately the community understood and worked with us in the process. So another important takeaway is your structure is incredibly important. You do need policies and procedures, especially if you are doing something like compensating members or offering transportation incentives, those policies need to be clear. What activities are paid for and what are not? When can they ask for a housing, or not housing, transportation stipend or childcare stipend, and when can they not? If you're asking them to show up in a formal way, like what is the expectation? Are there a certain amount of meetings you want them to meet? Making sure that you've defined what your shared vision and values are, that you have a clear way of working together. And we found that that makes community work a lot smoother. And so those are some fairly, organized and what can sometimes feel like rigid structures. So we often have to also flex and adapt. So when it's not working, we have to be willing to listen and say, okay, let's change the process. Let's change the procedures and let's do what works for community. And so that flexibility and adaptability and responsiveness to community is incredibly important. Logistics are also key. We have to think about when we are hosting our meetings. So some community partners may not be available during the workday, especially if they're working shift work where they have to clock in, they have to clock out, they have a very rigid lunch schedule that only offers them 30 minutes. So sometimes we may have to say, maybe we shift the meetings to nighttime. Or maybe we do half and half to make it to where both individuals can come, whether that's if they're only available during the day or if they're only available at night. Think about where you host your meetings. You want it to be in a space that is welcoming, inviting. So maybe your office building that has, a swipe badge access and feels really formal might not be the best place. Consider things like community centers, churches, and their community spaces are often really great, comfortable shared spaces that community are already going to and interacting in. Think about how you're hosting your meetings. Is it in person versus virtual? So we live in a virtual world now, and we know that Teams and Zoom have made it to where we can be more efficient. We can meet with people who are further away from us, but not everybody has the technology, or if they have the technology, they don't have the understanding of how to use it. So some community members, you may need to offer a training session of how Zoom or Teams works in advance of listening sessions or town halls where you're looking to engage your community partners. You may want to consider offering both types of opportunities. In person, some people really need and value that in-person connection for trust to be built, and so consider both. Think about language and access. So there's the physical access of the space. Is it physically accessible to people with ADA issues? So is there a wheelchair ramp? Is there an elevator if we're on not the first floor? Does it feel safe and comfortable for the people attending? Another thing to think about is language. So do we need to have translation or interpretation available? And if we do, we may need to think about budgeting that into our operating budget or grants that we are writing to work with the community. Also, people learn differently and absorb information differently. So we want to provide multiple ways to share that information and allow people to absorb it. So verbal, written, email, text, use multiple modalities when working with community partners. So one thing I want to do before we hear from our community experts is quickly reflect with this group about where we are in the process and how ready we feel in doing this work. And so I want to ask you 4 questions and then hear from you as a group. So do we have the trust and relationships with community to begin doing community engaged work? If yes, how do we sustain them and continue to build upon them? If you don't, what do you need to do to build ones that you don't have? Do you have the knowledge and expertise to do community engaged work as a team? Or if you don't, are you willing to learn? And if you need to learn, what capacity building do you feel like that you need to do? Do we have the capacity? And so sometimes the biggest mistake that we can make is jumping ahead of ourselves and saying, and getting really eager because of our best intentions and saying, let's do it. And then you really don't have the personnel resources, the time, or the bandwidth to engage with community the way that you want to. And so trust is broken once again because the engagement is not authentic, or you're having trouble holding your organizational commitments to the community. So sometimes the best choice is to say, right now, we're doing the most that we can. Do you have people at the table who look like and sound like the programs or initiatives that you are running? So it is representation there. And so I'd love to hear from some of you about where you feel like your organization currently is in this process, and also what are some things that you think that your organization could be doing better to increase your capacity to do authentic community engagement.
If I may, we just, with Thailand's help, we just finished our community health needs assessment back in, we did it in April. So a lot of things are learned, I feel, from 4 years to the next 4 years. So some of the things that we look into this time was the language, like you mentioned, the because sometimes, because we're used to have these conversations and we're very familiar with some of the terminology or the way we understand or explain things, we take it for granted that people in the community will feel the same way. So revising the questions, because looking back at, some of the things that were not finished or not answered, or were sessions that were skipped, it was important to pay attention to what happens with those. Are we using the proper language? Are we taking in consideration reading levels? And like you said, having a translator, there is a wide variety of the same language sometimes. So making sure that we're using terminology that is accessible to everybody. So those were some of the things that, looking back, we kind of like learned from the previous one.
That's a really good example. And I see that I think Katie has put up for us a poll for some of you to answer for a couple of these questions. If you want to do that while we're taking some feedback from the group. So do you have the trust and relationships with community to begin doing community engaged work? Yes, no, somewhat, not sure. Does your organization have the capacity to do community engaged work meaningfully and well? Yes, no, we could if we change some things. And so while people are sharing, if some of you wouldn't mind filling that out.
It's looking, Melissa, like it's a lot of yes, which is great in terms of being able to do that work meaningfully and well. And then do we have the trust and relationships to begin that community engaged work? Yes, we got 74% there, which is great. And then somewhat. And I like people being real about we could if we change some things, right? So I'm going to end the poll.
Melissa, one of the things that we've heard a lot of the work that you and I've been doing around this, especially during the landscape assessment and then talking to some of our pilot sites, is this issue around capacity, right?
Mhm.
And I think, if you're like an N of one responsible for the CHNA, like engaging the community almost feels impossible, right? Because it's just like you have a timeline, et cetera. Like thinking about all of these different practical takeaways and strategies you've shared, like one of the things that we know is that CHNAs, this is something that you don't have to compete with other healthcare systems, right? And so like how healthcare systems can partner and then also partner with their community partners to help get this work done. And we've used kind of, I don't, we kind of made this up with of like the banana pudding is there's many recipes out there for banana pudding, right? And so there's not one perfect way. Like, yes, there's the blue ribbon banana pudding that we're striving for, but like that we know that we're going to just do the best that we can. And one of the things that I really appreciate about this call and all of the people who are participating today is that we've got a lot of community partners on the call and who engage individuals with lived experience. Any response or thoughts about that you want to add?
Oh, for me or from
Yeah, like
the
or
group?
anybody, yes. But based on what you and I've learned together through this process.
Yeah, I mean, I think it's kind of exactly what you said, Pam, is that we all have a different recipe, and what works for one organization is not going to necessarily work for the next organization. And that's why when I say that continuum of community engagement, design intentional design for what works for you. And picking the community engagement strategies that you feel like you have the resources to support, both financially, personnel, organizationally. Also, what would your community respond to? That's the other thing is that it's not a one size fits all for your community partners. What do they want to do? How did they want to be engaged with? And so sometimes the easiest and most simple thing is to say, what role do you want to play in the process? And if they say, we just want you to hear us and consider our perspective, then that's what you need to design. You know, if they show up and say, we want to learn how to be, and we want to work towards a process of saying, being an active participant in this process, then maybe you need to consider what that would look like and how would you go about that. So it's finding the pieces of the puzzle or the recipe that works for you rather than looking at other communities and saying, that's what I have to strive for, or that's what I have to do.
Great.
So I think we are right on time and ready to transition to our community experts that Pam is going to introduce for us.
Thanks, Melissa. I'm very excited to introduce to you our two subject matter experts on this who have many, many years of experience as it relates to engaging the community and including through community health needs assessment. So let me introduce them to you quickly. So we have Dr. C.A.R.E. Cease. She joined Furman's Institute for the Advancement of Community Health as executive director in November of 2023. Previously, Cease co-founded the Bradshaw Institute for Community Child Health and Advocacy and led the pediatrics residency program and developed a number of clinical initiatives to close care gaps. She also directed the Pediatric Community Health and Needs Assessment for Prisma Health. She brings deep expertise in community health and innovative care solutions. We also have on the call today Renee Leonard-Gary. She's the Assistant Vice President of Community Health at Roper St. Francis Healthcare, where she leads the work of the Community Health Division. Renee has over 20 years of experience in various healthcare roles, and to date, Renee notes that spearheading the development of innovative community programs has been the most rewarding for her. So thank you, C.A.R.E. and Renee, for joining us today. And C.A.R.E., I'm going to hand it over to you to get us started and talk to us about your experience and expertise in engaging the community. Thank you for being here.
Great. Thank you for having me. I'm excited to share a little bit about my experience. And so as Pam mentioned, I specifically led the pediatric component of Prisma Health CHNA in the 2022 year. And in the 2019, both in 2019 and 2022, was part of the steering committee for Prisma Health's overall CHNA. In 2019, it was the first time that Prisma Health was Prisma Health, and it included the Midlands and the upstate region. And so some challenges of bringing two health systems who had done it differently together. Can share a little bit about that. And then in 2022, we added a specific pediatric arm of our community health needs assessment. So you can go to the next slide. I just want to talk about, Melissa hit on a lot of things, and I'm just going to share some examples of how we did that. But the three main points that I want you to keep in mind as I'm talking is how you move beyond the surveys, how you elevate community voice really through that qualitative process, those through your focus groups and interviews, and then how you really can engage the community in that prioritization process. So that's kind of going to be my roadmap as we talk a little bit today. So Melissa mentioned surveys really are the mainstay for most people's community health needs assessments. In both the 2019 and 2022 surveys, we engaged a lot of academic expertise and in our surveys, but I will say we probably did not engage as much community voice in it. So I was really happy to hear the last person who spoke about what their kind of lessons learned in terms of how they ask that survey. And that would definitely be advice that I would give now as you're creating those next surveys. Yes, we made sure that they were appropriate reading level, but you're going to get the answers to the questions that you ask. And so, making good questions is going to be really important so that you're getting a broad swath of information from your community. Some of the survey questions that we had are very disease specific. And when I compare that to Bon Secours, in our market, theirs were more around kind of the why and the social determinants. Between 2019 and 2022, we got better, I think, at asking those questions and trying to get to some of the root cause. Obviously, we were able to do a little bit more of that digging around root cause through our focus groups and interviews. But I think that you need to develop a really good survey. And I think getting community voice in that and reviewing that is really important. So that would definitely be a recommendation that I make. The other thing about your surveys is you should be doing check-ins around them. In South Carolina, our broadband, it's getting better, but so many of the surveys are, digital, right? So we're sending them out on our email listservs that we have. And as a health system, some of the emails that you might have may not be to the voice of the people that you're really wanting to get the information from. And so you're using social media, and this is really leaning into your partners here to help expand that survey out into your footprint is going to be hugely important. But also remember that digital literacy, if we learned anything from COVID, right, is that there's a huge digital literacy divide, not only in our immigrant population, but in our elderly population as well. And so what seems easy to take a survey online is not always. And if you are, really relying on a lot, it needs to be mobile friendly too. So every survey that is developed in Qualtrics or REDCap sometimes is not mobile friendly, and people are using their phone if they don't have access to other computer resources. So mobile friendly and really thinking about your digital literacy is really important. Making sure you have enough paper surveys and where you're going to use that, and really engaging those deep community partnerships. And I think to Melissa's point, right, do you have trust in community? Like if you're leaving these surveys out places for people, are they going, is there trust that that information is going to be used appropriately? So that's a key thing. And so using your trusted partners, your faith-based organizations, schools, that's where those deep community partnerships are really important, because that trusted messenger is going to be able to help you get those surveys reported more accurately. And then look at how many you're getting at a time. And if you can, do some of that analysis early on, like what is the demographic of who's filling these out, so that then you can use those trusted partners to enhance where you're seeing that you're not getting the survey responses. In 2022, our survey responses were huge at Prisma Health, but they were primarily white women, over the age of 50. And so that is not representative. Those responses represent me, right? That does not represent, the community that we necessarily want to serve. So then you're going to have to engage people to help weight those surveys to make sure that the data you're getting is actually, you're going to use data that's really important to the system, and that can be then trusted. And then again, Melissa already mentioned this, but then sharing that back with community, that it does, is this right? Is this representative of where we're, the information that you wanted to share with us? Because if it's not, then you could do more targeted approaches to get those surveys. You're on a bit of a time crunch, right, to meet the IRS guidelines of when it's done and when it's posted. But I think being smart about looking in, how many surveys do we have? Where are they from? So that you can do your targeted survey outreach and using those trusted partners. And so one thing I just want to add here too is, the survey again is your primary data that you're going to be getting in. And it is this being strategic about how you do this, really strengthens your health system's reputation in the community and builds that trust. And that's important. So yes, you're checking a box and doing the things that you have to do, to meet IRS and ACA requirements. But really, this helps you build that trust that Melissa and Pam talked about in the beginning. So doing this right and thinking about how you engage with community and sharing data back with them with the data that you're getting is really going to build your reputation of your institution, which is, should be equally as important for that. So that's kind of moving beyond the surveys and using the surveys really appropriately. And some of the strategies that we use, like I said, is, looking at that data regularly and then figuring out how we could get that, bolster up our surveys. And then when we didn't, how we weighted the data to make sure that we could interpret it in a way that was meaningful for our community. The second thing that I want to say is, how can you then elevate community voice through the qualitative process? And so, some folks maybe we're using surveys and that's all we can do right now, and that's great. If you can move beyond the surveys and think about focus groups and targeted interviews with community members, you really using the tools that Melissa talked about is really how do you elevate the community voice in that. And I would suggest, if you can, it takes more time, is as you're developing those focus group guides, vet those with community. If you have a community advisory board or you have other coalitions that you're working with, are these the questions, again, that are going to get us to those the whys and the root answers that you want to do? And I think all too often in Prisma Health, we did the same thing. It was very much, and we used our academic partners to help us with that. But now with more experience, I think we really should have vetted more of those with community, and that would be a recommendation that I would give to people, so that those focus groups are, again, getting you the answers that are going to help drive your chip, right? All of this information is to say, is this data going to help drive to community improvement, and how do we use it with our community to get to that next step of community improvement? So I think the more you engage community in that, the more you're going to have them meaningfully participating in that, and getting you the answers so that when you go to develop your chip, they're going to be more bought in with that. And I think when you're also in that qualitative process are the data walks back to the community, right? Did we get this right? Did we interpret what you said appropriately? I think that is really, really important. Your community partners here are also really important. And Melissa hit on so many things that I was going to share already. Like, where are you doing these? Who's helping you get those groups to get the voice to the table? Asking the community too, like, whose voice do we need at the table? What are we missing? Who is underrepresented in our health system? And not from the health system deciding who's underrepresented, but who does the community feel like his voice is not being heard? And so you have to have that trust, and you have to go out and ask those questions. We did a lot of that, and were able to come up with very specific groups that we wanted to have, and they looked different in the Midlands than they did in the Upstate, and that's appropriate, right? It should look different because your communities are different. And then how do we use our community partners? How do we partner with our community to make sure that the representation for who we're recruiting for those focus groups is appropriately representing who we want it to represent. And I think, we did not do a really good job, I think, of vetting those focus group questions. But that would be something I would definitely do different. And then the last part that I want to talk about is the prioritization piece. Because that's really important, because that's what's going to drive then your next step is the CHIP. I think we've done it the 2 times that I was part of Prisma Health, and Darren, I don't know how you guys did it this year. You could pop in, or Angel, I saw you were on the call. One time we did it, and I think our prioritization involved community much more so than the other way that we did it. So the prioritization one year was very much just done internally. It was Prisma Health prioritized it. Their rankings were done, and then the prioritization was done a lot based on budget, which I think is totally appropriate, because you also can't prioritize things and promise to community things that you can't do. And I think that is really, really important. We used in 2019, we used this modified Monte Carlo method, where you essentially, all these things bubble up to the top, right? When you do your analysis, both your primary and your secondary data come up to say, okay, these are the things that are really important. Now, how are we going to prioritize what we're going to do? And so this, the modified Monte Carlo method, essentially you're saying, you ask multiple questions and you have people kind of force rank against each other. And so, like, yes, this is a priority in our community. Yes, if we had funding to do it, this would raise to the top. Yes, we think there's kind of will of the community to do this. And then the hospital system can say, yes, we're going to prioritize this as well. We're going to put some budget towards it. It's a little bit more complex than I'm explaining, but there's multiple ways that you kind of rank against each other that helps. So this may be your number one priority, but if there's no will and no funding, then we're not going to prioritize that for this round, right? Because that would be disingenuous of everyone to do. And so the best way to do that is to engage community in that prioritization, right? So, and I think the wheel that Melissa shared, all those people on that wheel, the business community, your service providers, everybody should be focusing in, I think should have a vote in that prioritization. Ultimately, obviously, the health system is responsible for putting those together, but I think getting the voice of all those people is really important. When you engage community in that way, in that decision making, people feel valued and heard. And then when you move to the CHIP, which I'm really more excited to be talking about how you engage in that process. If you've engaged them all along the way, again, through the surveys and getting surveys, understanding their voice in the qualitative component and the prioritization, they're much more likely to stay engaged with you when we're talking about the CHIP process. And that, you're building trust all along through the CHNA process. And then it's just so much easier to get people involved in the CHIP. It does take time, it takes investment, but the trust building component from that from the beginning makes the next few steps that you have to go through that much more effective.
C.A.R.E, thank you so much. I'm glad you touched on the prioritization, because that's what our next webinar will be in the beginning of January 2026. So, Renee, please share with us your wisdom that you have today on engaging the community, all of your many, many years.
Thank you, Pam. I think Dr. C.A.R.E gave me a great segue into the trust building part. If we get to my slide, I kind of highlighted some of the things that I know Melissa already covered, and I think it ties it up real nice from what Melissa went through and what C.A.R.E just went through. But really starting from the space of our role here in the Tri-County, I do represent St. Francis Healthcare, but I think the strength in my input to this session is the fact that we have developed coalition through our Healthy Tri-County initiative, where we worked with 3 area hospitals and actually the Trident United Way to conduct our community health needs assessment. But as the lead nonprofit health system at St. Francis, who's required to conduct a community health needs assessment, it was strategic for us to think about our long-term experiences of informing and consulting with our community and the public. And as C.A.R.E said, that trust building. So it was a great segue into that. We took that trust building that we had from our first assessment that I was a part of here at Roper St. Francis in 2013. And then in 2016, really allowed ourselves to get more involved with the community. You know, when you start your baseline assessment and you probably have 100 surveys or 300 surveys with the small intimate group that you have, you learn that there's opportunity, and you hear that opportunity by consulting your public and community partners. And so from that and that involved stage of this work on the community engagement continuum, we really felt like we could have more momentum with that public inclusion for greater participation. And so we learned that through efforts such as community forums and think tank sessions, some of the things already mentioned. So those were the vehicles that we used to really lean into the community and really hear back from them and take it to the next level. So that involvement, it does open up for that two-way communication more versus us coming as a health system and providing the information from our data collection with surveys and our qualitative assessments, sometimes with very small focus groups. And then also just, you know, leaning in when we're thinking about what are we developing within the health system, consulting those partners on a one-off or now every 3 years, right? And what we heard in some of that feedback time was that, well, you know, you come, you do the survey, you collect the information, but we want to know more and we want to hear more. And so I think that took us to the next level after we built momentum around the community health needs assessment and sharing what it was and why it was so important. And that many of us, health systems, community partners, have been doing it for a long time, just it doesn't always get published, right? And now there's, you know, the need to publish it. I think moving us to the collaboration phase of it was the next step that I want to highlight in our coalition. So from being involved, it prompted us after our 2016 Healthy Tri-County Community Health Needs Assessment and partnering with the Medical University, Trident Health, Trident United Way, and Roper St. Francis being at the table, we decided that we could do this survey collectively. And that was a great opportunity. We had great alignment in 2016, and that actually was the catalyst. The Community Health Needs Assessment was the catalyst for us to develop a coalition called Healthy Tri-County at the time. So you talk about building momentum and fostering something out of a exercise. We saw strength in that. But again, that came from our trust building in the community through our informing and consulting as a collective. And so in that collaboration, you know, you get more of that bi-directional, you get the partners that start talking and people want to be a part of it. And so I think from my experience being a part of this process since 2016 as a collective, it was that, you know, launching the health assessment work was to make sure that we had all community partners who wanted to be involved, not just the health systems. But I would say this is really where we lifted the theory of collective impact, right? The shared goal was to get the health assessment more robust, to get more data insights, more qualitative data. But we knew as an individual health system or as the core partners that I mentioned of this Healthy Tri-County Collaborative, we knew we couldn't do it alone, right? No one organization can handle it all. So being strategic on the collaboration front helped us really move the needle in our survey collection to go from about 1,500 assessments in 2016 to over 5,000 in 2019 was phenomenal. But as C.A.R.E stated, even though you have 5,000 respondents, when they look like her and have that demographic, you know that sometimes you might need to pivot. And so I would say the strength in our collaboration when we conducted the 2019 assessment was that we could test what that pivot would look like, work with our partners to make sure that we were intentional about identifying the right groups. If we saw that in the initial survey responses that we were getting, that we weren't getting the sample that we were looking for, or that was representative our community. For us in the Tri-County, each county even looks different. So you have to think about that, but to make sure you're getting a representative group as you're looking to build that momentum. I say here with the move the needle around survey collection, it was to do things that were not our traditional ways. It was to do things out of the box. I can remember in that year utilizing the fact that we had a annual parade that we participated in and developing QR codes to hand out when we went to the parade in communities that we knew we needed more voice from, and handing it out with whether it was a chapstick or sunglasses or whatever, and having that QR code to have everyone be a part of and share the messaging. There was events that we had around particular affiliations that we would participate in their events. Like, we didn't have to always lead when you talk about collaboration. We didn't always have to host, but we could be there and be a part of and disseminate the survey, right? And then also get some of our volunteers behind that. We had in our collaborative, it was multi-sector. So we had relationships with the faith community, the business community, academic, our social, and also our health. And so we utilize that as a strength. As they're developing programs and hosting different community events, we were there to help with data collection. And so those agency partners also were key to that, because we gave them some responsibility, right? Like, we didn't have to lead the work all the time. So we utilized their public presence and their community relations to say, hey, can you host a community forum? Can you bring the community to the table and host? And then also help us with some of the logistics behind it. Help us with focus groups. If you get them there, what we then did was also take the relationships that we had with our academic institutions here. I mean, if you know the Charleston Tri-County area, we have the Medical University, we have Charleston Southern, the College of Charleston, the Trident Technical College. So at that time, for that last assessment that we had in 2019 and then in 2022, is where we leveraged having both community health workers, which I'm sure you guys, many of you on the call are familiar with that role, and also our students. And we took a training, no shame in borrowing. I think it might have been from the Center for Community Health Alignment at the time, borrowing from them on a training they had around being able to conduct qualitative assessments. And so we took that and did the in-house training of those CHWs and students to help us with the focus groups and collecting the data from key informants as well. So not only were we leveraging the wealth of assets that we had in the Tri-County area, we were also training them on the pathways of their career as well, which will help them in their career mobility. So we kind of turned it upside down in the last two assessments that we had in 2019 and 2022. But where I lean in here in the example around collaboration was this past year for our 2025 Community Health Needs Assessment, which we'll be launching this month, was really taking that whole relationship we already had. We already participated in an annual parade here. Actually, it was the MLK parade. We worked with one of our faith partners that was downtown Charleston and worked with them to do exactly that, host a forum after the parade. And we also worked with one of our civic organizations who came out, and we kind of had a hot dog and hamburger ministry outside of the church. And that church at the time is Mother Emanuel, having those faith partner relationships and them welcoming us in. And so we were able to, even if people didn't know what we were doing, they saw the food, they saw the engagement, they wanted to know why we were there. And so that allowed us to be able to get a more diverse group of people too at that event. So leveraging what we already had built. And then last, I will highlight the point about leading. I think that is something that is a sweet spot. Not everybody probably could get there. And I see that as kind of a mastery level when you're building a coalition. The CHNA prioritized by the community partners and by community agencies, they pledged to be a part of this health collaborative. So there was times where we could allow them to lead in different areas. And in that came the development of, when we identified what those top needs were, that we could get subcommittees and working groups around that, and having co-chairs or having staff designated to help us with the assessment and the development of that. But also we talked about very briefly about implementation and plans and prioritization. So they are key in that step too, identifying those agencies who can lead that work where we as core partners didn't always have to lead. And then my last comment here around the lead portion of that is that with our Healthy Tri-County Collaborative, we have seen COVID come. We have seen some shift in leadership, exchanges where we had leaders from different hospitals go to other areas, or some people retire. And so what I will say, the part about leading through a collaborative around CHNA is that when everyone's at the table and invested, they can lead at different times. And so what that looked like was maybe MUSC stepped up in the interim when Roper St. Francis couldn't be there, or another institution couldn't be there. And we find ourselves in this place right now. But I think we have a plan of action where I might be leading this 3 years or in the next 5, and someone else might be leading in another effort. But I think we already have strength in numbers, and it's a popular exercise initiative here in the Tri-County area that everyone's eager to be a part of. And I will pause there.
Thank you, Renee. I really appreciate you and C.A.R.E sharing your insights and all the experience that you have in terms of conducting CHNAs. Here's an opportunity, folks, to ask questions of our subject matter experts, and you can put them in the chat box or raise your hand. But I do have a question I would pose to both of you, and just while we wait for those questions. And also, folks, if you put a question in the chat box and we don't get to it, because we probably won't, we only have a couple minutes, we're going to create a FAQs document with those questions, and we will share them back out with you with responses. So feel free again to put those in there. Yes, the PowerPoint slides will be sent out. But let me ask you guys, so, when you're engaging the community, there's sometimes we might run into the challenge where there's some priorities that the community feel like these are the top priorities, and then our healthcare system feels like these are the top priorities. How do you align that when you run into that challenge? Have you run into that challenge, and then what would you do in that situation? And Renee, I think maybe y'all had a similar situation.
Yeah, I think, our addressing the priority needs, they're pretty robust. For us, we usually have 5, right? 5 priorities that we were looking at. And again, doing that assessment of who's at the table and who's the expert in some areas allowed us to say, for the example, clinical preventive services is one of the top 5 priorities that we've identified. And within that is embedded diabetes management and diabetes prevention. Well, yes, we come from the health system, but there's a community partner that was better seated to be the hub of diabetes prevention. Like, we didn't have to lead it, they could. And what we could do is get behind them and support them, and being able to get grant initiatives to help them develop and accelerate that program. So I think that's a good example where we as a health system, or health systems, didn't have to own it. We had an organization that was a community-based organization that could lead that work, because it was more authentic engagement than what we probably could give as a health system.
And C.A.R.E, do you have like 1 minute you want to share on that before we hit our last few slides to wrap up our call today?
Yeah, I think I would just add to what Renee said. I think the way we handled that was in the CHIP process, actually. And so when, the prioritization happened, and then when you're thinking about how do you actually deal with it, I think that's where maybe the health system and the community had different ideas. And to Renee's point, we did exactly the same thing. Like, Prisma Health didn't have to lead this part, right? And so who is the organization that can, and how, and we even wrote that in our action plan, right? Where it's going to be support or advocate for, right? And we didn't have to lead that part. And so I do think that even when those are a little bit different, you can, that's where partnering and collaborating and the health system showing up beside your partner is really important.
Fantastic. Thanks so much, both of y'all, for being on here with us today. And I'm going to hand it over to Katie so she can wrap us up with the upcoming events.
Yeah. Oh my gosh. Thank you all so much. And if you could please join me with a little reaction or come off mute and give a little clap. Thank you so much to our guest speakers and to Melissa and Pam for their great content today. Thank you all so much for your participation. Upcoming, please save the date. February 5th from 1 p.m. to 2:30 p.m. We have our first 2026 webinar. It's going to be on prioritizing those community issues. C.A.R.E talked about that briefly, but how can you take that data that you've collected from the community, make it useful, present it well, all these different prioritization processes, how to do that, and what are the best practices. So we're looking forward to being with you. You can RSVP via ad event. I'm going to put that link in the chat. You can just go ahead and put that to on your calendar right now so you have it. We'll also, of course, be sending out reminder emails. And then you can also use this cute little QR code with the little dinosaur in the middle with your phone if you want to use the ad event to RSVP there. That helps us know how many folks to prepare for. And then, of course, it's already in the chat. Melissa, if you could go to the next slide, please. Oh, we'll talk for the Health for All Summit. I'll turn it over to Landon, but if you could please fill out the meeting evaluation, we'll have the links for that in a second.
All right, I know we just had it briefly on the previous slide, but we do have our next Alliance event coming up in the spring. So that will be our Health for All Conference or Summit. That's going to be on April 14th at the Columbia Metropolitan Convention Center. If you guys have any specific questions regarding the event, please reach out to Hannah or I. We'd be happy to answer those. Otherwise, we will be sure to add any new information that comes up as far as our speakers are concerned, the agenda and so forth, as those are finalized in the upcoming months. I'll hand it back to Katie to finish this out.
That is it. I am just, sitting here begging you to please fill out the meeting feedback form. It really helps us understand what we did well, what we need to improve, and how we can move forward in the future. Please provide any suggestions for the 2026, like what your needs are in terms of developing CHNAs and CHIPs and what kind of information you'd like from us. We'd love to hear from you. So that link is in the chat, and the RSVP link is also in there. That's it.
Thank
Pam,
you, everyone.
Melissa,
have a great.
Thank you for everything.
Yeah, we appreciate everyone joining, and please join us for the next one.
Great day.
You all have a wonderful day.
Thank you all so much.